Welcome everybody to Neurology Journal Club. I'm Tony Amato. I'm Chief of Neuromuscular at the Brigham and Women's Hospital, and I'm joined by Dr. Paloma Gonzalez-Perez, very close colleague who runs the myopathy section at the Mass General, and picked a article and accompanying editorial that, as associate editor, I liked in regards to inclusion body myositis, and the focus of the papers were really, is there this entity of COX negative polymyositis, or is this all IBM? And the problem with diagnosis in IBM, it's been kind of murky since, the original description many years ago was a case report, and the term was phrased inclusion body myositis, but it was a patient who was in the 20s with a foot drop. And we all know that's not IBM, though it was called IBM, and it wasn't until Carpenter-Kapady had a larger series of older patients that really is the inclusion body myositis that we have. But the first patient ever reported, we probably now know, has probably had GNE myopathy. And another thing, the inclusions that were described, and a lot of people don't know, was not the rim vacuoles, which is a canonical feature of IBM, but it was the inclusions that were seen, the filaments that were seen on electron microscopy, that a lot of people make mistakes and they read biopsies and they see a rim vacuole and they say there's inclusions. And then early on, kind of like with Carpenter and Kapady, and there was a nice paper in Brain by Lutz and Engel that talked about IBM. And again, it was a very histologically defined entity, and had a little bit of the features, and mentioned about some having distal finger flexor weakness. And when I was a fellow in 1991, 1992, Jerry Mendel always taught me about the finger flexors being weak in IBM and out of proportion to the shoulders and the quads. But that was never really, and so that was a clinical feature, but still the diagnostic feature was based on the biopsy. But as a young guy then, when I was in practice, I was seeing a bunch of patients that had clinical features that I said had to be IBM, and the biopsy showed inflammation, but maybe 20 or 30% of these patients did not have rim vacuoles or amyloid that I could see, or other kind of inclusions, but they didn't get better with immunotherapy. So I thought that they probably had IBM. And Birch Griggs, in about 1995, I got some senior IBM researchers together to develop kind of criteria. And what I had sent in, Rick Barron presented, was features of patients who I had seen that had diagnostic IBM and a biopsy, patients who we called polymyositis on the biopsy alone, but they didn't respond to treatment. And then polymyositis, what we called, that responded, and again showed that these unresponsive polys really looked identical to inclusion body myositis. And with that information, Griggs kind of went and made the Griggs criteria of having, you had definite IBM if you had the pathologic features, but you could still have IBM if you had clinical features, but you were missing some of the features like rim vacuoles or filaments on EM. And I published our series in Annals of Neurology called Clinical and Pathological Boundaries, in which I was even more strongly, and I said it wasn't probable IBM or possible IBM, but it was probable IBM. This kind of, that I think, again, how the clinical features, sorry to say, trump the biopsy features. The biopsy features are are helpful that you don't always have to have rim vacuoles, and you're going to be missing on 20 or 30% of biopsies. And the other pearl, I would say, pathologists would always issue reports that you couldn't see amyloid, and that's because they're looking at on paraffin sections most of the time. And I was Jerry Mendel's fellow at Ohio State when he first reported amyloid, but it's only on frozen sections that you would see amyloid on Congo red. That's not where most pathologists do it. They only use frozens in surgery on brain and tumors, to get a quick read. Everything else is process and paraffin, but process of paraffinizing muscle tissue gets rid of the amyloid. Another little pearl, but kind of with this then, in the mid-90s too, was some people also started saying, well, they didn't see rim vacuoles, but what they saw was Cox negative fibers, and still calling it polymyositis, even though the clinical features looked exactly like IBM. And there was, mixed thing about whether patients got better with treatment or not. I've never seen them get better. And I've always thought this was just IBM, and most people do, but there's still this thing in the literature about mitochondrial Cox negative polymyositis, and that could lead to, the bad thing is it can lead to treatment with immunotherapies, which are toxic and don't do anything. And so that's why I thought this paper, and I wanted an editorial with it to really kind of emphasize that to people. And again, I'll let Paloma take it away.
Yeah, thank you so much. It's my pleasure to discuss this paper with you. And I think it's a very important topic and bring a lot of questions to the field that I think are important for clinical practice and also research. So this paper that we are discussing today, the title Morphologic and Molecular Patterns of Polymyositis with Mitochondrial Pathology and Inclusion Body Myositis, published by Clifford and colleagues in Neurology. And I think the first thing that we should comment on is the table 1. Well, the first will be the question. They, as Dr. Amato said, many authors think that PM-Mito and inclusion body myositis are part of the same spectrum of the disease, and this has been a topic for many years now. But this paper we are discussing today, the question is to see if they can identify a common molecular signature for patients with PM-Mito and inclusion body myositis patients. So what they do is basically they select a limited panel of 41 RNAs, and they are going to determine the expression of these genes in muscle biopsies from patients with PM-Mito. And these patients with PM-Mito were classified as PM-Mito based on biopsy, not based on clinical features. And also some patients with inclusion body myositis, and also patients who don't have any disease, who are controls, non-disease controls. So, and then in addition to this real-time qPCR that they do to determine the level of expression of these genes, the 41 genes, they also want to know if patients with PM-Mito biopsies have these cryptic exons that were previously reported in patients with inclusion body myositis, because if they see that in PM-Mito, looks like maybe they can also prove or support this common molecular signature between both groups. And let me comment on table 1 because I think it's important to know who are these patients with who are classified as PM-Mito. And these 25 patients, all of them were older than 45 years old. And I think it's important to say that the time or the age at which the biopsy was done is similar in patients with PM-Mito and patients with inclusion body myositis. And I think this is important also in terms of the number of Cox negative fibers, because they don't see any difference. So yeah, all patients older than 45 years old, and there is a female predominance in the PM-Mito group, and a male predominance in the inclusion body myositis group. And in terms of the phenotype, which is something that it's very interesting to me, 4 out of these 25 patients have this, what they call incomplete inclusion body myositis pattern, not meeting criteria for clinically clinically defined IBM, but some features on exam suggestive of inclusion body myositis without meeting clinical criteria for IBM. These are only 4 patients. 16 had proximal lower extremity weakness or proximal lower and upper extremity weakness without any suggestion of IBM. These are 16 of them. 3 of them had myalgias, which is interesting because some PM-Mito patients that were reported before also sometimes have only muscle pain and nothing else. So 3 of them had myalgias. And then a total of 2 were asymptomatic, 2 didn't have any symptoms. We don't know why the biopsy was done yet, but 2 didn't have any symptoms. A total of 7 had swallowing problems. And then in addition, they were diagnosed, 8 of these patients were diagnosed with other diseases, most of them connective tissue diseases. And 14 patients out of these 25 patients had some clinical follow-up. And in this follow-up, 13 out of these 14, so more than 90%, were diagnosed eventually with inclusion body myositis. I think this is a very good, for me, it's a very strong point that these patients, at least, more than 90% progress to inclusion body myositis. In terms of antibody data, there are 2 patients with a positive TIF1 antibody. We don't know what that means. I mean, it is an antibody associated with dermatomyositis and cancer, but none of these 2 patients had any cancer or dermatomyositis. And then 6 of these patients were tested for the IBM antibody, right? The NT5C1A antibody. 6 were tested for that, and 2 were positive. So this is the 25 patients with PM-Mito. As I said, 13 out of the 14 for which they had follow-up, develop eventually inclusion body myositis. So these are the patients. And then we have the 3 groups, inclusion body myositis, PM-Mito, and the controls. And in figure 1, they have this panel of 41 genes that they want to know the expression level for patients in these 3 groups. In figure 1, they include only those genes that are related, those genes from this panel that are related to the interferon pathways. So figure 1A is interferon 1, and figure 1B is interferon 2. And they see that actually patients with inclusion body, this is in muscle biopsy, is gene expression in muscle biopsy. And they see that muscle biopsies from patients with inclusion body myositis and muscle biopsies from patients with PM-Mito share more or less the same level of expression of these genes that are related to the interferon pathways. And these similarities are more pronounced when they see the genes that are related to interferon 2 are more pronounced than with interferon 1 gene. So this is the common thing that they have when they compare with the controls. It is not shown in the slide, but they also see that genes that are related to the proliferation, activation, and proliferation of the T cells are also very similar in terms of expression of these genes in patients with inclusion body myositis and patients with PM-Mito when they compare with the control. So these are the common genes that they see with these 2 groups. On the other hand, in supplemental figure 2 and also in figure 3, they also see some genes that are very different or in terms of the expression level between inclusion body myositis and patients with PM-Mito. For example, in the supplemental figure 2, you see that at least CD244 and CD28, which are markers of T cell differentiation. This is different from T cell activation or proliferation. So T cell differentiation, these 2 markers at least are much more upregulated in muscle biopsies from patients with inclusion body myositis than in patients with PM-Mito. So this is a difference for these 2 groups. And then in figure 3, I think one of the main figures of the paper, I can say, they see that there are other 2 genes, that is GBP6 and KLRG1, that are also much more regulated in patients with inclusion body myositis than in patients with PM-Mito. Actually, the authors call these 2 markers like the black and white markers because can differentiate the 2 groups quite well. So they show also this muscle biopsy that you can see in the first part of figure 3, And you can see at the top a muscle biopsy from a patient with PM-Mito, and at the bottom a muscle biopsy of a patient with inclusion body myositis. And you see that the staining for GBP6 and the staining for KLRG1 is much stronger in the muscle biopsy of the inclusion body myositis. So here a little bit explain what is the GBP6 and KLRG1. So GBP6 is a GTPase and is induced by the interferon pathways, and KLRG1 is a marker of the highly differentiated cytotoxic T cells. Okay, so these are the main two markers that they report on the paper, and they also do some, as you can see here in the supplemental figure 5, they do some double immunofluorescence study to see where these two markers localize or co-localize with. And you can see in this figure on the left is a biopsy of a patient with PM-Mito, and on the right is a patient with inclusion body myositis, right? So then you can see in red the GBP6 and the KLRG1, right? See that, let's focus on the muscle biopsy of the patient with inclusion body myositis, because it's going to be easier, I think, to see that the GBP6 co-localize with the green marker, which is the CD206, which is a marker for macrophages. So they conclude that the GBP6 co-localize with macrophage cells, and the KLRG1 co-localize, not surprisingly, with CD8, which is the marker of the cytotoxic T cells, right? So, and this colocalization is much more pronounced, as you can see in the muscle biopsy of the patient with inclusion body myositis than in the muscle biopsy of the patient with PM-Mito. So these changes or this expression of these markers is much more pronounced in the patient with inclusion body myositis. So another thing that they show is, and I didn't put this figure in the slide, is figure 4. It's like they define like 4 stages, pathological stages, when they analyze the muscle biopsy of all these patients, and they basically call a mild PM-Mito stage, a typical PM-Mito stage, a pre-IBM stage, and IBM stage. So, and then the inflammation and the variation of the fiber size gets worse as the stage progresses. But there are, I think, 2 important points. It's like the number of COX-negative fibers is the same across groups, so there are no difference. So I will say a patient with inclusion body myositis, I will think that may have more COX-negative fibers than a patient with PM-Mito, if we are suspecting that, if we know that they are part of the same disease spectrum, but they don't see difference in the number of COX-negative fibers. And another thing that you mentioned and they also see is like the rim vacuoles or inclusions, P62 inclusions, or the staining with LC3, which is another staining for another marker for macrophages. They only see that in patients with muscle biopsies of patients with inclusion body myositis. They don't see rim vacuoles in PM-Mito, or they don't see P62 staining in PM-Mito, which is something that I think we know from other papers, but they confirm that too. And then they have these 2 patients out of these 25 patients with PM-Mito that were rebiopsy. And they had another biopsy, one of them 5 years later and another one 7 years later. And they were eventually diagnosed with inclusion body myositis. And this is, they showed the biopsy, the 2 biopsies for one of these patients in figure 5. And again, you can see a little bit, I mean, it's good to have some longitudinal data for at least 2 patients. And you can see that the first biopsy is staying a little bit for KLRG1 and GBP6, right, on the left, but then the second biopsy, you can see stronger staining for KLRG1 and also stronger staining for GBP6. Interestingly, here they comment that the GBP6 here probably is staining the macrophages, but also they see staining for this marker in the sarcoplasm of the muscle fiber, not only in the macrophages. So I like this longitudinal data in the same patient and how, but on the other hand, it's another biopsy, it's another location in the muscle. So maybe it was there before, right? And so obviously the muscle biopsy, we just take a sample, right? So. And then the last thing that they do is to see if from another study, actually from Brigham and colleagues in 2022, we know that in muscle biopsies of patients with inclusion body myositis, they saw the presence of cryptic exons in different genes. And so basically this was published as a manifestation of the TDP43 pathology that we see in patients with inclusion body myositis. So here the reasoning is like the TDP43 should be in the nucleus, right? But in inclusion body myositis, the TDP43 is outside the nucleus and has an abnormal function. So the TDP43 should control the splicing of different genes, and when the TDP43 is not functioning well, so the splicing in other genes can be abnormal, and then these cryptic exons are included in other genes as a manifestation of this abnormal splicing. So this was all demonstrated by Brigham and colleagues in 2022. But these authors here in this paper, they want to see if they see the same also in patients that are classified as PM-Mito. So they show in this supplementary figure 1, they show these 4 genes, and we need to see. I mean, we need to focus on the blue shading for each of these genes, because this is the region of the cryptic exon, and you can see that for IBM patients, you can see that the high expression or the high presence of the cryptic exons in these muscle biopsies, and then for PM-Mito patients, you can see that there is a little bit of the presence of these cryptic exons in the muscle biopsies. However, for the controls, they don't see much. Okay, so this is, I think, another experiment that favored this common molecular signature for patients with PM-Mito and patients with inclusion body myositis, but this molecular signature is much more pronounced in patients with inclusion body myositis. So at the end, the authors claim that, again, this is like a spectrum, not only clinical spectrum, and as many already pointed out over the years, but also a molecular spectrum. So, and I think this is another very important figure of the paper. So I think these are the most important findings. I think, as I said, that this paper brings many, support the idea of the spectrum, IBM spectrum disease, and then, but bring maybe even more questions to the field. I'm very interested to see, it's for me interesting the phenotype of patients with PM-Mito. Not all of them apparently have like an IBM phenotype. So I think, I wonder if we know everything about patients with PM-Mito, and if all of them progress to inclusion body myositis, if we can say that.
We have patients that present with dysphagia. We have patients that present with a head drop. We have patients that only present with hip girdle weakness and not arms. So to say that it's an early spectrum, we see the same variable patterns in patients that have all the canonical features of IBM. So it's a lot. I know we're running out of time. Trying to split this group out, as something different. And I think it's dangerous. I just say, why, and I don't think, as they were saying, calling this early IBM, we don't know that it's early IBM. And, it's a tiny one piece of muscle, and where we know there's a lot of sampling problems. And I would just call these patients IBM, and otherwise you're going to get you know, you run the risk of not having them involved in clinical trials, but most can be involved in clinical trials. But more importantly, that they might get treated as a polymyositis with immunotherapy and not get better and just suffer toxic consequences. I mean, and wrap it up, you know, I mean, the editorial by Dr. Greenberg, I don't have enough time to go over this, kind of goes over a lot of this too, and emphasizes how he thinks that these are all, this is really the same disease. And offers suggestions again on looking at diagnostic criteria, the clinical features. If you have inflammation on the biopsy and with invasion of fibers, and you have finger flexor weakness, that alone is like 95% specific and sensitive.
Yeah,
you don't need to say whether you have, you know, amyloid or rim vacuoles or P62 inclusions. That's just that is the most sensitive and specific. Finger flexors and inflammation on the biopsy.
Yeah, no, totally agree. And we have to make sure before, right, comment on, you know, I'm thinking on a patient, for example, with myalgias and a PM-Mito biopsy, what we do, but maybe that patient with myalgias didn't have a proper exam and maybe has some finger flexion weakness, right? So it's not only myalgias, it's something. So yeah, the thing to me, I think many of these PM-Mito patients may be included in the clinical trials.
Well, they are because again, they're included when they use European Neuromuscular Foundation criteria.
Exactly.
The latest, they go to, you have clinically and pathologically defined if you have all the features on a biopsy and you have all the clinical features, but it's probable if you're missing, say, rim vacuoles, but they have finger flexors and knee extensors, then it's still called possible if you have finger flexors weaker than shoulders, which again, as I said, 96% of patients are gonna have that. And so, you know, you're not excluding anybody, really. These patients are in trials for IBM usually, if you do a good exam. Maybe that's what we have and we could wrap it up, but I think that was the salient things. And I think you did a great job discussing this, and again, the importance of the papers and just trying to you know, put a nail in the coffin of PM-Mito and just call it IBM.
It was my pleasure discussing with you this interesting.
Thank you for joining me.
Thank you for joining too. Yeah.
Have a good day.
Thank you too.